Thank you all for joining the first of our expert talks. We hope you find this a really interesting and informative. There's the opportunity to ask questions towards the end of the presentation using the chat box at the right hand side of your screen. I'm really pleased to be able to introduce to give the first of our talks for year 22-23, Dr Rob Haigh, who is our medical director, and he will take you through some reflections on our COVID journey. So I'll hand over to Rob.
Thanks very much indeed, Glenn. Well, good evening, and I don't know how many people will be able to join us in the end, but it's a pleasure to talk to everybody who's taken time out of busy schedules, I'm sure, to attend this first session. Obviously, we're testing the water slightly in terms of how to best sort of place these, and hope that this is going to be something that people will enjoy and find helpful and informative. Certainly, Glenn and Jan and I have had a busy day, I have to say, because we've had our colleagues from the CQC with us today, and that's midway through their review, and we're very pleased to have had them today. So my brief for this discussion was to speak a bit about my sort of perspective on COVID, but also where we've how we've moved things as an organisation over the last 2 years. And if I could have the next slide, please, Jan, if you don't mind. It began. I'll just let the slide change. Lovely, thanks very much. Brighton, actually, which is where a lot of my work takes place, in fact the vast majority, was one of the first places in the country to actually encounter COVID, or coronavirus as it was called back then. And it's actually quite difficult to retrace our steps right the way back to the 6th of February in 2020, when Steve Walsh, who was a local Brighton man, hit the headlines both locally in terms of Brighton and Worthing, and also nationally, because of course all of a sudden we had the 3rd case of COVID in the UK. Brighton was where Steve Walsh lived, and he'd been working abroad. If I can have the next slide, please, Jan, that would be really helpful. Before we met Steve, things had been moving quite quickly. Here's a diary of the sort of national perspective of that first week, between the 23rd and 30th of January, which was when the first 2 cases of COVID-19, as it subsequently became named, were identified in the UK. These were 2 Chinese students, actually, who'd recently come back to the UK from Wuhan, and were studying at the university in York. And the 3rd case in the UK was Steve, who was a resident in Brighton, as I've already mentioned. And although the picture in China was deteriorating, there was still a sense, or at least a hope, that COVID would be contained. How little did we know? And if I can move on to the next slide, please, Jan. Steve was a patient at the Royal Sussex County for a little while, and we had to track and trace everywhere that he had been, and also everybody that he'd come in contact with. And this was the sort of local journey. This was just his movements prior to his assessment at the county hospital within Sussex. But prior to this, he'd been on an international conference in China with Chinese delegates, maybe in Singapore, actually, flown home to the UK, travelled by train back to his home, and then travelled to a ski resort in the French Alps and come home again. And looking back, I have to say, and remember, this is only just over 2 years ago, 2 years and probably 3 months ago, the idea, looking back, that we might have been able to contain or track and trace all of his contacts was clearly very naive. but I'll remind everybody again, if we move on to the next slide, please, Jan, that it was all very uncertain and very new to us then. And in fact, I vividly remember 12 people in my relatively small office in the county hospital on a conference call to Public Health England, as it was called then. It's now called the Health Security Agency, but Public Health England was its former name. And we had a spider phone like this in the middle of a table with a group of us talking to Public Health England and also to the scientists at Porton Down, because already there was enormous interest and concern that there was one case of COVID in the south of England. So 12 of us in my office, no masks, no social distancing, a spider phone, as I've mentioned, because there was no Teams facility at that point. And I remember somebody from Public Health England saying we're really, really worried about this virus, which seems to hail from China. Or somebody else saying to us within the team, either at PHE or at Porton Down, that this could potentially turn out to be something of a disaster. So on the next slide, quite soon afterwards, things did take a bit of a turn, but instead of Brighton this time, it was our Worthing site that was quite significantly affected. So a few days after Mr. Walsh tested positive in Brighton, one of his friends, who happened to be a GP actually, was working in the A&E department at Worthing, which was a regular place that they worked, and they also tested positive. And so we were given very strict guidance and instruction by, pardon me, Public Health England on how to track and trace individuals that may have come in contact with our colleague who was working in the Worthing ED. We knew very little about the spread of the virus at that time, of course. There were no national protocols in place. There were no lateral flow tests. There were no guidance, or there was no guidance or recommendation that was certain, because this was the very early stages, even though it was February 2 years ago. And PHE and the Health Security Agency, now called, advised us to quarantine all staff, all people in fact, including patients that have come in contact with the GP, and we identified 25 members of staff amongst the Worthing A&E team who were close contacts of the GP, and so they needed to quarantine at home. That was important for obvious reasons, but it was also important from our perspective as an organisation, because of course this was the first example we had of the potential impact of COVID in terms of staff absence, and of course regrettably decimated the ED team for a period at Worthing. But we were able to use our merging organisation really positively and provide mutual aid, in fact, from Brighton. So although Brighton had had the first case, none of the staff in ED had been exposed, and it was therefore a great opportunity, and the first time that we employed joint working between the respective hospital sites. And for about a weekend and a few days afterwards, it was Brighton doctors and nurses and other professionals that were working and supporting the Worthing ED team, and that has progressed and really developed over the last 2 years, such that mutual aid in all sorts of different aspects is something that we use and rely on frequently. And maybe we'll exemplify that again further down the line. So if we could move to the next slide, please, Jan. Things moved quite quickly, as you will no doubt all remember. In the first year of COVID, our supermarkets and our communities noted that the pandemic was evolving and everything was changing. People came out of their homes to clap for NHS staff on a Thursday evening. You'll probably all remember that. Individuals and organisations did quite extraordinary things to raise funds for NHS charities, but of course we also were led by fear, and stockpiling took place. And the lack of toilet rolls that we can see on these shelves in these supermarkets was mirrored in the struggle to supply adequate PPE to the NHS, and that's something that we've also had to help manage and work closely together as a new merged organisation to ensure that we support each other and provide adequate stocks and supplies of reagents, of testing kits, of PPE, very importantly, of a range of other things, including staff, as I've already mentioned. I'll take the next two slides quite quickly, if I may, Jan. So these are a couple of slides that demonstrate at the Brighton site some of the changes that we had to make, and we still have in place actually, around segregating our potential COVID patients from people who attend hospital who are very unlikely to have COVID. And this has happened in every hospital in the country. And this was the footprint, a sort of schematic footprint of the ED department at the county site in Brighton. And you can see the sort of distribution of different clinical capacity, ranging from cubicles to chairs to resus to majors, what we call the majors, and also to minors in ED. And on the next slide, Jan, what you can see is how we had to hive off a whole section of that to work in a completely different way in order to provide clear steering channels for our red patients and our green patients as they became known, and also to provide care for a range of new initiatives and treatments. We added all sorts of different treatment modalities to our armoury for managing COVID, but this required very clear separation and segregation of patients, as I've already mentioned. And as a result of that, we lost quite a significant amount of space in ED, 17 clinical spaces, in fact, in the Brighton ED, and 6 in the acute assessment unit as well. And we began to really take notice about our stocks, our supplies, even our oxygen levels on a daily basis, because there were examples in the country where hospitals had almost or actually completely run out of oxygen due to the unprecedented demand caused by the respiratory illness associated with COVID in those early stages. We started meeting and planning our response to what was now a major incident across the whole of the NHS by meeting regularly, and we'd have 35 or 40 of us standing in the boardroom at Brighton to attend meetings and briefings. Social distancing hadn't been recommended at that stage, but of course we very quickly learned how important that was to become, and moved all our meetings, as we are discussing tonight, onto Teams. And we took also incredibly seriously across society the impact of a cough and cold. I mean, how many doctors, nurses, allied health professionals, support workers across the NHS have attended work in previous years with coughs and colds and sneezes? And of course, very quickly we learned that we needed to isolate such people and ask them not to come to work because of the potential threat of cross-infectivity of what we now knew was potentially an incredibly serious new virus. If we move to the next slide, please, Jan. PPE dominated the national and also the local agenda, I have to say. And in the first wave, and we're talking here sort of spring and summer in 2020, you know, we learned very quickly about the importance of adequate gowns, gloves, proper fitting surgical face masks and visors, and you know, staff became used to wearing such important equipment for 12, often more hours of work, and this was really difficult. You know, they genuinely and literally showed scars on their faces as a result of abrasion from tightly fitting masks. And as I've mentioned already, PPE availability was really stretched across the NHS, and you will have heard and read about a lot of that in the national press as well as locally, I'm sure. But we are a big organisation, and across the 4 sites we were really able to help support each other, and gowns that were surplus in Brighton were donated to Worthing and St Richard's, and at other times gowns that were available and masks and visors at St Richard's and Worthing were used to support depleting supplies in Brighton and Havesheath at Princess Royal. We introduced new materials management to make sure that we never ran out of PPE, and that was essential because throughout the whole of the pandemic, of course, it was essential that we maintained and preserved patient safety at all costs. Staff safety as well became very clear, and we'll mention that again at the end. So if I could turn to the next slide, please, Jan. February to really sort of October, November were really quite difficult in that first wave of the pandemic. People were working very long hours in quite difficult conditions and managing huge volumes of patients with COVID, many of whom, of course, very sadly lost their lives during that time. But things really did take a big turn for the better, and a real turn round the corner in December, and it was December the 2nd, 2020, so about 9 months after we'd first met our very first case of COVID in Brighton. The first vaccine was licensed, the Pfizer vaccine was licensed for widespread use, and at the Royal Sussex County Hospital we were very proud to participate in the first day of COVID vaccinations nationally, which was the 8th of December. Sorry, it says it was licensed on the 2nd, of course, but the first vaccines were actually administered on the 8th. We were pipped, I have to say, as an organisation by the team in Oxford, who were on the national news very early that morning, as you will probably remember. But it was about 8 or 9 o'clock in the morning that colleagues, and you can see on this slide, you may recognise Mr. Kali Valadasaran, who was at that stage our Director of Medical Education, and also Dr Rob Haigh, who is in the second picture on the left there, one of our A&E consultants, who were 2 of our first staff to receive vaccines. And the right there, I feel I have to acknowledge and want to acknowledge the wonderful leadership shown by our then Deputy Chief Executive, Dr George Finlay, who, as you can see there, has been interviewed by TV shortly after the vaccine became available in Sussex. And George, of course, is rejoining us next month, sorry, the beginning of June, the end of May, beginning of June, as our Chief Executive and successor to Dame Marianne. Vaccine really did give hope in terms of horizon scanning, and people thronged, I have to say, to get their jabs. It was an absolutely extraordinary undertaking, and will stay in the minds of all those who participated in the vaccine rollout within Sussex and nationally, of course. I'm sure it will stay with them for the rest of their careers. And vaccines provided us with this massive step forwards, and we did start to see some improvement in COVID numbers. And what was really, really reassuring and wonderful to be part of was the impact of vaccination in terms of saving lives and people not developing those same very serious respiratory complications. And if we move on to the next slide, please, Jan. We've progressively learned to live with COVID really since vaccination became available. So over the year 2021 and the start of this year. We've lived through multiple variants. We've lived through adapting strategies and health advice. And interestingly, the last wave, and I'll show you some data in a minute that supports this, the last wave, the Omicron and what we call BA2 wave has been probably the toughest of all. Our staff, our people that work with us have been tired. Staff absence has been very high because it's had to be. Our hospitals have been incredibly busy during the last wave with A&E attendances and patients really returning, inpatient numbers really returning to the sort of pre-pandemic levels. And we've also had to manage a lot of patients who are medically ready for discharge but aren't quite able to leave hospital yet because the next step of their pathway can't be easily provided, and a lot of that relates to the availability of rehabilitation facilities or domiciliary care, and as a system, Sussex is working really hard to improve that and making some strides. So although the virus is still virulent, thankfully it's less severe than it was right at the beginning, and we're starting to adapt to a more normal life. And certainly on all 4 of our hospital sites, we continue to keep a very careful eye on COVID, on the numbers of patients. We screen every single admission into hospital as an emergency, at least, with a PCR test, and we undertake lateral flow testing for our elective admissions by and large now. It's essential that we continue to keep our patients and our staff safe because we still have plenty of COVID around. I'll move on to the next slide, please, Jan. As well as vaccination at the start of 2022 and the incredible effort to roll that out nationally, the other thing that's been happening during the last year has been the development of new treatments, so that we've got an armory now of modern therapeutic agents that can help support and reduce the impact of COVID in patients who are unlucky enough to contract it and have to come into hospital. And I'm just going to spend a couple of minutes now talking about some of these new treatments because they do give us real hope, I think, for the future, and I'll show you why. The first of these are something called neutralizing monoclonal antibodies, and these are synthetic proteins which behave in the same way as human antibodies in the immune system, and they neutralize the virus by attaching themselves onto the most important part of the virus that enables it to replicate in human cells and cause all the damage in the lungs that it does. They stick on the virus and, if you like, put a lid on it and prevent it from entering the tissue, the lung tissue. We all were very dubious, or at least I was, early on last year when President Trump, as he was then, caught COVID. Excuse me, I do beg your pardon, I'll just silence that. Caught COVID and was discharged from hospital quite quickly, having had antibodies provided to him. And we were all a bit unsure as to exactly how worthwhile and reliable that was. But as you will see in a minute, it really is a very important aspect of our treatment now. And the other thing that we've done over the last year is to recognise that by giving patients treatment very early and managing them carefully and looking at their oxygen requirements, we've been able to treat a vastly greater number of patients out of hospital rather than relying on having to admit them all to hospital. And if I can move on to the next slide, please, Jan, which I acknowledge looks quite, there's a lot of information on here. I'd like you to focus. This is an overview from this week, actually. It was refreshed only yesterday, of how much COVID there is in the southeast region now. So the southeast region extends from Kent, from Medway, in fact, in the east, right the way across to Oxford and Southampton in the west, and takes into account the so-called Thames corridor, I think, which is Berkshire and Buckinghamshire and Oxfordshire, as I've already mentioned. And I spoke a little while ago, didn't I, about the impact of the most recent wave of COVID, and you can see there that compared to a year ago, March 2020, we saw vastly higher numbers of inpatients with COVID. This time we saw an increase in our numbers of patients requiring ITU, but these were not nearly as great as they'd been in previous waves. So that ITU spike from 2021 is incredibly important, isn't it? And that's where we really struggled. You will see that the numbers of patients in that middle box on the right hand side occupying critical care now is very, very much lower than it has been in previous waves. Pardon me, and that's really important to note. And if we look at the numbers of admissions in the bottom right hand box there with COVID, we'll see that although we had to carry quite a significant burden during March, that was nothing compared to the number of inpatients that we had in the same time last year. However, the absolute numbers of COVID cases in our community and amongst our staff was as high as it has ever been. But of course, we are now managing a very different illness. And if I can move on to the next slide, please, Jan, which I think gives us some hope about how COVID is likely to potentially develop over the next year. Please don't take any notice of all the different colours on here, apart from those blocks in the top, which are called molnupiravir, Paxlovid, remdesivir, Ronapreve, and sotrovimab. And what these are the 5 agents that we use now, particularly in our most vulnerable patients, those who have immune system impairment, and we administer either tablet or intravenous treatment. One of those, the yellow box, is called Ronapreve. That was the neutralizing antibody that President Trump received, actually, and we have been using a newer and more effective agent in this country called sotrovimab. And we've been giving a lot of it over the last few months. About across the southeast region, about 6,000 patients have benefited from these new treatments. And what I want to show you on the next slide, which is the really important message, I think, for the future, is that the top bar there represents 5,226 patients who received either infusions of antibodies or oral treatment over the last 4 months in the southeast region. And then the middle box represents a further, of those 5,226 patients having received treatment, you will see that only 264 of them needed to come into hospital, and thankfully only 14 of them died. And the reason this is such an important chart to share with everybody is because these treatments are only given currently to our most vulnerable patients. These are our patients with very clear evidence of immune suppression or paresis or impairment. So patients, for example, with HIV, with organ transplants, with leukemias, with other cancers, with complex immune modulated diseases like rheumatoid arthritis, pardon me, or inflammatory bowel disease. And we are able to now select patients very early if they have evidence of COVID and give them these treatments, and it, as you will see, materially improves their survival and their outcome and their risk of hospitalization. Had we not had these treatments, and we'd been looking at this, a year ago, 14 months ago, I have absolutely no doubt that out of 5,226 patients in this category, at least 1,000 perhaps as many as 1,500 of them would have died from COVID. So thankfully, we are making real strides in the treatment. Okay, as I come to the end now, I just want to mention two other things, if I may, and I'll move to the next slide. If I may, Jan, we've done everything we can to keep our staff as safe as we possibly could, but sadly we have lost 2 members of staff as a result of COVID, and it's important that we pay tribute to those that we've lost. And I'll just let you read these very small but incredibly sincere and genuine reflections on our 2 staff members who have passed away as a result of COVID since the pandemic started. Obviously, we're very sad about those, but I think about those 2 and the families that have been bereaved as a consequence of their passing. But I think the last slide that I showed you, I hope, does demonstrate that we do have real hope now in terms of our fight against COVID. There has been some change in the natural virulence of the COVID virus. That's going in the right way, in the right direction at the moment. We can't guarantee that that won't reverse at some stage. So progressing the science and getting better understanding of therapeutic options is the way that we will continue to save the lives of countless hundreds of thousands of patients now across the country. The final thing I'd like to do before I finish and ask if anybody wants to ask any questions, and Glenn will field those, is to ask you to help spread the word by looking to recruit new members who represent the population and the communities that we serve across West and East Sussex and Brighton and Hove and Mid Sussex. And there are a number of ways in which members of the public can become involved, and all of those relatively small numbers who've attended this evening, I would be grateful, and certainly Glenn and Jan would be very grateful if you could pass on the importance of getting involved in supporting your local hospitals. There are some advantages to that, as you will see in the middle paragraph there. But it's a really great thing to do, and we rely on feedback and support from our population in every aspect of the care that we provide. And so my personal support for members of the public who wish to become involved in our organisation in a very proactive way will always be there. So I think, if I may, at that point, Glenn, I will pause, and then if there are any questions, we'll try and help answer them.
So yeah, so thank you all for attending. As Rob just takes a little drink. We've had one question in that Rob will seek to give an answer to. Obviously, it is an opinion rather than anything else. But as Rob had mentioned, we value you becoming members of the trust. You may already be members. I encourage your friends and family to join. This is the first of a series of talks that we want to put on for our members, and obviously a way that you can find out is to become a member of the trust, and we'll be able to get in touch with you and alert you to these much earlier than if you're a member of the public. So thank you for joining. So Rob, there's just been one question. I think you can see that.
I can actually, yeah. Thanks very much, Lynn. I hope it was a helpful presentation. So will we get how far can we go with new treatments, I think is what Lynn's asking. Will we get to a point where we'll be able to look at separation and segregation of patients in a different way? I think the answer to that is yes. I think as we become more and more experienced in living with COVID, providing the virus continues to behave in the way it has done over the last year, and the opportunities to intervene as early as possible to prevent deterioration progress, then I'm reasonably confident that we will be able to lessen the red ward load in our organisations and in our hospital sites and across our organisation. We're not going to be able to get there quickly, but if I let you know the most recent figures that I've got access to in terms of our hospital inpatients, it was about 45 between the county site and Princess Royal yesterday, with 25 of those, 30 maybe at the county, and about 10 or 15 at Princess Royal. And in the West, if my memory serves me right, correct me if I'm wrong, Glenn, it was about a similar number, actually, just slightly fewer. So already we're seeing, you know, a significant downturn in the number of COVID inpatients. And as that progresses, and I think there is genuine optimism by the public health teams that support the modelling around COVID, that as we move further into summer, the numbers will decrease further. What is really, really important, however, is keeping a very careful eye on the groups of patients that are remaining vulnerable to COVID infection, and particularly those that are then getting reinfected. And we've seen some evidence of that in other parts of the country. Thankfully, these are not patients who are becoming seriously ill. They're getting cold-like symptoms, runny noses, sore throats, streaming eyes, headaches, general aches, and so on, but they're not needing hospital admission. But that sort of rate of reinfection and the way in which it affects different patient cohorts, I think will determine the next sort of rollout of vaccine. And many of you will be aware that already we've started rolling out a fourth dose of vaccine to our over 75-year-olds, for example. So that's a slightly long-winded way of saying, Lynn, I think we're getting to where we need to get to, and we will be able to reduce our bed capacity. It's not going to be a quick fix. I think it's going to be later on in the year before we have a lot of confidence about that.
Yeah, Alan, there was one other question, Rob, that I think I just put out a sequence, which is around, would it be possible to comment, if we are able to, on why we feel there were so many doctors that we lost nationally in the awful period before we started to have a solid vaccination, and they were from an ethnic minority?
Yeah, I think that's a really important question, and we did lose a number of staff, and we lost an awful number of people who from ethnic minority backgrounds, and it's a very complex story. There is an increase in associated conditions that predispose to the risk of COVID amongst some of our minority ethnic groups within English and UK society. Conditions like diabetes are more prevalent, and heart disease and hypertension can be more prevalent, and they are associated with a worse outcome if one then happens to become infected with COVID. And that's a really important factor, because what that means is that we need to improve our overall health of our population and reach out to vulnerable groups, be they vulnerable because of immune insufficiency or paresis, or vulnerable because of ethnicity or social deprivation as well. And we do need to do that, and regrettably that and are doing that. Regrettably, that did manifest itself in terms of both the medical and nursing professions in the early stages of the pandemic. And one of the reasons why, of course, healthcare staff of all professional backgrounds and disciplines were some of the first, along with social caring staff, to receive the vaccine when it became available in the UK.
Thank you, Rob. We had a question about putting the link for our membership in the chat, which we have done, and then we've had a further question, Rob, Thanking you for the talk, which yeah, I think everybody will agree. Just asking, the COVID treatments that you spoke about in your presentation, are they expensive or difficult to make, and are these treatments selectively given, and is there a risk in giving some treatments over others?
Really good question. So the answer is yes to all of those. They have been expensive, but thankfully we have a National Health Service. The development has been very rapid. We have a National Health Service, and the costs of these agents are currently at least covered by central government. That will change, but that will be through normal commissioning processes. So I'm not worried about that at all. The intravenous treatments do have some restrictions, but they're in terms of patients in whom they're contraindicated, but they largely revolve around allergic reactions to similar products previously, so they are actually very safe. We have 2 or 3 now commonly used oral agents. One has with it a longer list of contraindications than the other 2, but it's also very much the most effective. So we look very hard at reasons to give it, and we're very careful to make sure that we don't put any patients at risk. And thankfully, if the most effective of all the oral agents isn't available, we have 2 others that are perhaps not quite as effective, but still effective, but have a much kinder side effect profile. And I think it's really important that we continue to develop these drugs, and new agents are coming online all the time. In the same way as there is a multiplicity of agents to treat high blood pressure, for example, I think we'll soon get to a situation where we have not a huge range, but a significant menu of options in which to provide the right COVID treatment for individual patients. Hope that helps.
Thank you very much, Rob. I can't see.
I'm only seeing one question here, which is a comment from you, actually, Glenn.
No, I think you're looking on my screen rather than the published screen, Rob. So that's fine. I can't see any other further questions. So I just wanted to thank everybody for your attendance today, and we hope you enjoyed the talk. And thank you, Rob, for taking the time out of your very busy day to give us that update. Just want to close off by saying please keep a lookout for our next talk, which we plan to give in June, and we will let people know through our information databases. So thank you all, and again, thank you, Rob, for taking time at the end of your day.
My pleasure. Thanks, everybody.
Thank you. Bye all.